Namaskar, hello, good evening to one and all. Myself, Bhalchandra Joshi. I welcome you to this CAP Masterclass with Dr. Deepak Talwar sir, who would be guiding us on various tips and tricks and current trends in the management of LRTs. The today's agenda. So we'll start this program with Dr. Talwar sir, who would be speaking on current trends in management of LRTS, followed by question and answer and panel discussion. This is the brief agenda. So I'll request Modi sir to please introduce Dr. Talwar sir to the audience.
Good evening and thank you everyone. And it's my privilege to welcome Dr. Deepak Talwar, who's a very well known pulmonologist, not only in India, but of course globally. And we all always look forward to have some interaction with him. All our PG students also, if they ask me, who's the one person in India where you look after us, I say that you go and meet Dr. Deepak Talwar. So he's like a mentor, a fatherly figure, and very, very knowledgeable academician. And I was just talking to him that how do you manage all these things together? Best academician, plus a best clinician, and a very good administrator also. So thank you and thank you for coming to Pune. So he has done MD, DTCD, DNB and DM in pulmonary and critical care medicine. He is director and chair of pulmonary sleep and critical care medicine at Metro Institute of Health Sciences at Noida. He is fellow of American College of Chest Physicians and National College of Chest Physicians of India, fellow of Indian Sleep Disorder Association, fellow Indian College of Allergy and Immunology. He is a teaching in charge of DNB respiratory medicine since 2008 and fellowship program in interventional pulmonology under IAB and ICS. Awarded Legend in Pulmonology by Times of India and Best Pulmonologist of India by Economic Times. Published 82 research papers in indexed PubMed journals, including NEJM and Clinical Infectious Diseases, BMJ, Chest and Respirology, Asthma, Allergy and Clinical Immunology, and American Journal of Respiratory and Critical Care Medicine, that is our blue journal, and ERJ. So I think his biodata, if I have to read, it's definitely it's going to be vast, but I again thank him from the bottom of my heart for coming over to Pune, and he will be taking us through this topic of masterclass in community acquired pneumonia and management of lower respiratory infections. So thank you, Professor.
Good evening, everyone. And it's really a pleasure to be in this city and being introduced so nicely by Dr. Modi. And I always envy the way he talks. Like, it's so clear and so effortless that it seems that it's coming from the bottom of the heart. So I think very genuine person. I have been watching you for the last many years and I'm really admirer of you, let me tell you, and admit that actually. Today, I'm going to talk about some newer trends in lower respiratory tract infections. And I think this is a sequel to, there were 3 modules on community acquired pneumonias and community acquired pneumonias during COVID, and then some issues related to controversies in community acquired pneumonia, which were webcast in the last 2 years of COVID. And now this is I think the fourth of the module, which is on focusing on the lower respiratory tract infections and something new, which has primarily come in the last I think a year or 2. So obviously it's quite a huge topic and I won't be able to cover the most of the things. So what I'm going to do is just try to give you a snapshot summary of whatever is the current things as far as this topic is concerned. Obviously the importance of lower respiratory tract infection primarily comes because it's still the leading cause of mortality all across the world and including India. So you can see that nearly about 5 million people die of diseases which are either directly or indirectly related to lower respiratory tract infection, and it's the leading cause of death. And obviously that's one of the main caveat out of it, is that how can we improve the outcomes. So if there's a disease which is common and there's a disease which is causing a lot of loss of lives, the next question to physician is that how can I do better? So can we have some newer understandings to be incorporated in our daily practice which can help us? So first of all, the lower respiratory tract is a bucket definition. So it's in this bucket you have all infections which can involve the lower respiratory tract, which is anything which is below the vocal cords. So tracheitis, tracheobronchitis, bronchiolitis, and finally the pneumonia. The difference between all lower respiratory tract infection and a pneumonia is the chest X-ray showing a shadow which is consistent with the diagnosis of pneumonia. But more important than that is that the lower respiratory tract infection which carries the maximum mortality is a community-acquired pneumonia. And this is very sad to see that despite all the antibiotics and everything being available to us for the last 2 decades or 3 decades, we still continue to lose patients with a community-acquired pneumonia. Why should it ever happen actually? But this is not a phenomenon which is seen in India. It's word across. Everywhere the patients of community-acquired pneumonia do die. And we always wonder that how can we improve their survival by looking back into whatever is available to us in the diagnostics as well as in the treatment aspects of community-acquired pneumonia. Chest X-ray is missing 1 out of 4 cases of community-acquired pneumonia. So obviously because of the various factors, and sensitivity and the specificity is to the tune of about 75%. Maximum if it's used digital films, and now there is a lot of talk about using AI with the digital films to pick up the diagnosis and improve it, but there also it reaches to another 5% or so. Ultrasound, which is in the hands of the physicians now, in the emergency room, in the intensive care units, and practically the critical care has taken over the ultrasound in a way where the first thing which is available to a resident is actually an ultrasound to do it if it's available. So can the ultrasound improve the diagnosis of a community-acquired pneumonia? So this has been discussed a number of times. All it needs is actually 12 minutes to do an ultrasound of chest, and the sensitivity increases to almost 85% and above. So what it means is that if you are trained, you can pick up a diagnosis of pneumonia in a patient of lower respiratory tract infection by a quick ultrasound, which is done in 3 different levels on the right as well as 3 on the left sides. And you have these lines drawn anteriorly in the axilla as well as posteriorly, and you can quickly scan your patient for the diagnosis of a community-acquired pneumonia. What would be the difference? The difference is that the moment the label of community-acquired pneumonia comes versus a lower respiratory tract infection, you know that the mortality rates have jumped, and you need to take this patient more seriously and fast track. Very importantly, fast track the patient. And as you know that, I'm not going to repeat whatever I have done in the previous master classes, is the most important thing is your decision regarding to allocate the patient into appropriate place. Whether he goes home, or he gets treated into the ward, or he gets into the intensive care unit. That's going to determine the outcome of the patient. If you miscalculate this kind of a decision, then even if you correct it after the patient has deteriorated, you do not improve the outcomes. The outcomes remains the same. So you admit in the ward, the patient deteriorates, you shift the patient into the ICU. Still this patient's mortality rates are much higher had he been directly allocated to the intensive care unit. So there are algorithms for that, and we keep discussing about that. But yes, a quick ultrasound in the emergency room is one of the answers to pick up those patients who are coming with the lower respiratory tract infection. When we look at the mortality rates in the pneumonia and the survival after an attack of pneumonia, it is definitely decreased, and you can see that it's nearly or statistically not much different whether you develop a hospital-acquired pneumonia or you develop a community-acquired pneumonia and you are admitted in the hospital. So the entire mortality statistics of community-acquired pneumonia being lower is primarily because a large number of them will be treated from home at their own homes because they don't have a severe community-acquired pneumonia or even a moderately severe community-acquired pneumonia which requires the admission. But definitely the mortality of hospital-acquired pneumonia is nearly 2 to 3 times of what is seen in community-acquired pneumonia. So there is a significant burden of this lower respiratory tract even in India. And obviously we know that in children as well as in adults as well as in elderly population. All three populations are susceptible to have community-acquired pneumonia with some kind of a mortality figure on them, whichever age group they belong to. We know the risk factors are extremely elderly population, and we are now seeing more and more elderly population. But more importantly is the changing etiology. And changing etiology is where we are seeing more and more viral infections causing pneumonia. So if you go back and look at your previous last months or couple of months experience after the COVID, you will still be able to see that you lost a lot of patients with the viral pneumonias in comparison to your bacterial pneumonias. So viral pneumonias have come up with vengeance, and there is a lot of things which are happening, particularly in the early diagnosis of viral pneumonias. And of course, as the industry will be driven, more and more antiviral drugs will be available to us to treat them. But of course, at the moment, influenza is the most important one which we are talking about, and it is still coming. Last 3 months, I do not know about Pune because Pune has a different climate. But any patient who dies in our ICU in the north is actually an influenza pneumonia, whether it is an H1N1 or a non-H1N1. They are the ones, and they are coming almost like COVID, and you start wondering that they're so sick, but they have a different like bronchopneumonia. So you know this is not a COVID pneumonia. COVID is negative, and H1N1 is coming out to be positive. They are even coming influenza A positive and dying. And then you start wondering that why influenza patients are also dying. So is there a change in dynamics which has happened in the last 3 years? And this is a ever evolving dynamics in the community acquired pneumonias. You know, we define community acquired pneumonias by various ways, but ultimately the most important thing is where the patient comes from. Is he coming from the community or is he coming from the hospital? And that's the determinant of not only the likely causative organisms, but also the outcomes of the patients. When we look at the bacterial etiology, there are about 20 studies from across India which are trying to look into the bacterial etiology. This is the only one which I am projecting because this is which shows that gram-negative organisms are the most common ones. But by and large, Streptococcus pneumoniae is still the commonest organism, responsible for about 1/3 of community-acquired pneumonias, followed by viral pneumonias. And viral pneumonias are being picked up more because we have a diagnostic armamentarium to pick up the viral infections now. These kind of studies which shows that gram-negatives are very common are primarily from the tertiary care centers where patients get transferred after being admitted with a community-acquired pneumonia in another hospital and then finally get into by the time they reach the tertiary care hospitals, big hospitals, they already have a colonization or a superadded infection with gram-negative. But then to keep in mind that we might be also having a community-acquired pneumonia with more of gram-negatives, considering that the risk factors for gram-negatives will also be a huge population of patients which we have, particularly patients with airway diseases as well as other chronic respiratory diseases. So let's look at it. That has the guidelines changed a bit over a period of time, realizing what's happened in last 5 years on community-acquired pneumonia? So still they talk about, when we talk about a community-acquired pneumonia, you need to test for virus for all the patients who are admitting into the hospital for influenza testing. So at least influenza testing, after nearly about, I think it's been 20 years since the influenza is going on and getting recognized, now the guidelines have said that now you should look for and do the test for influenza virus, particularly when the patient is getting admitted in the hospital. You may not do it for the patients who are in the OP getting treated, but definitely those who get hospitalized. So not routinely recommended, but very importantly, you need to use a NAA testing, that is nucleic acid amplification testing for doing that. So I'll come to the rapid diagnostics a little later, but this is what is required. What about other non-influenza viruses? So I'm not going to talk about COVID today, but the second runner on this list of viral pneumonias after influenza is actually an RSV pneumonia. And RSV pneumonia, since we do not have a therapeutics for it, but let me tell you that the therapeutics is already on the anvil, but it is too expensive at the moment. But I'm sure when it comes to India, our patients will be able to afford even the management of RSV infections. And also the vaccination for RSV is coming. So we have other viruses besides influenza which can be looked into, and they are all being put onto the PCR platforms where you can pick up from the respiratory tract infections. So these other non-viral, non-influenza viral testings are again recommended in the group of patients who get into the hospital, and they have factors where this kind of viruses will make them worse outcomes or give them worse outcomes. So these are immunocompromised people, and classically they are neutropenic, patients who are on chemotherapies, solid organ or a blood component transplantation, patients with an advanced HIV disease, and patients who are on chronic immunosuppressive therapies. And here, very important to highlight is that oral corticosteroids in the dose of 20 milligrams and above for more than 30 days is now being considered as one of the immunosuppressive condition where you need to keep it in mind. And we have lots of these patients who are on such kind of therapies. So such patients you need to do, and particularly this data has come up from again the RSV, which is primarily attacks in this group of patients and has got very poor outcomes. What about using various kind of, the rapid testing tests? So we have the urine for Legionella, urine for Streptococcus pneumoniae, and blood cultures, respiratory cultures. Can we be done for all patients for community-acquired pneumonia? And if you see the ATS-ITSA guidelines, they are very clear that all these tests should be done in the patients who are admitted in the hospital, and preferably definitely in those group of patients who are admitted with a severe community-acquired pneumonia. So severe community-acquired pneumonia are those patients who are getting into the intensive care unit. So these patients would require this kind of testings, but non-severe CAP, there may be not a much indication to use all these tests because there will be false positives, and there may be some confusion created by these tests, which are basically on the rapid diagnostic testing lines. Risk of progression is a very important thing which is to be upfront assessed when you admit your patients. And there are multiple situations which are mentioned here, which are the indicators that this patient who gets into the hospital with community-acquired pneumonia tonight may not look sick, but by the time you come back tomorrow morning to see the patient may be looking very, very sick. So these are the kind of things where you need to anticipate the worsening, which is likely to happen in next 24 hours in these patients who obviously don't look very sick. Advancing age is the most important thing, comorbid conditions and other features at the time of admission, which are in the clinical findings or the lab findings, are the ones, and you can see all of them written here, and you know most of them basically. But we need to look into the identifiers in those patients who are likely to be the severe CAP. As I told you, there's a British study which you would have already come across, which showed that on the looks of the patients when they get into the ICU versus wards, and they get misclassified or represented to be shifted into the wards. After the collapse, once they are shifted into the intensive care units, there's no point because their mortalities are not improved by even shifting them at that point of time. So severity illness is to be judged right from the point of the admission itself. And there are multiple factors. I'm not again going into them. But many of them are incorporated into the ATS-ITSA guidelines, which you would have seen that they have a scoring systems for that. And these scoring systems are not only very lengthy, they are very difficult to apply. And in fact, the people who had actually invented this, they themselves are very rarely using them because they are very, very cumbersome to be used. So more cumbersome, more likely to be reflective, but less likely to be used. More simple, more likely to be used, but it is going to be less informative. So that is why if you look at the Indian guidelines, they only tell you to do CRB 65, because CRB 65 tells you whether the mortality is going to be 2% or it is going to be 35%, depending upon the number of factors positive out of that CRB 65, which does not require any test. We all know, I am not again going into that, everybody is nodding head that we know what is CRB 65. So I'm sure that Indian guidelines have gone well on that, that at least CRB 65 is known to everybody. Now these rapid antigen tests have been introduced, and you have seen that in the last 3 years, lots of them are available in India also. And they use multiple platforms and multiple testing kits. And you can see from this picture that all of them have a different sensitivity and specificity. And most of the times it is difficult for us to interpret that which lab is doing which platform and what is its sensitivity and specificity. Because according to us, a rapid antigen test means that it must be the same, whether it is done at A or B or C, whether it is done in Delhi, Noida or Pune or Mumbai, it should be the same, but it's not. So whichever testing ground is being used by these companies, it must be known to us, and that will tell us that what are the false positivity and false negativity of them. So you can see them, although the specificity is very high, it is like 95% and above. But then if you look at the sensitivities, they are all in the ranges of 60 to 80%. 80 is the maximum, but by and large, they are about 65% or so, which is like 2/3. But the specificity is very high. So that is why where the cultures are lacking, then the rapid antigen tests are the ones which are coming up. And these are all PCR based tests, and we have this multiplex PCRs where they are generally putting in 28 to 35 different organisms antigen testings, and the PCR based testings, but they are more expensive and take a little longer time. But now I am sure that even here it must be available where the results come, I think, within 2 hours, and you have the idea of what is going on. But I think ordering the test is easier, but interpreting the test is much more difficult, because when they come up with a drug-resistant organisms and the organism which you do not anticipate in that patient, then I think you land up into a trouble in interpreting those. So you need to understand that they need to be utilized even today for a lower respiratory tract infection with a lot of prudence. You really need to see that if the reports are going to be positive, or if the reports are going to be negative, how are you going to take in your treatment algorithm of the patient, how you are going to use that. If you do not know the answer, don't get the test. I remember Dr. Jindal always taught us one thing: don't order any test when it comes out to be positive or negative, you do not know what to do with it. So better you should have beforehand an idea of that if this test comes out to be positive, what I am going to do, and if it is going to come out to be negative, then what I am going to do. And that happens with this multiplex PCR. So invariably it confuses you a lot, because suddenly you will find a very resistant organism which you don't anticipate in a patient at all, but getting it positive, you might be actually forced to treat it. So in that scenario, obviously antibiotic abuse as well as whatever we talk about misuse will be of tremendous potential, considering that we need to understand how to use them. Serum procalcitonin. Now this is also in the last, I think, decade come up with a noise, and the noise has almost become like an echo. And it's a big thing in the last 3 to 4 years, where PCT has arrived into the intensive care unit as a point of care test. So it's become a POC. So you have a PCT kits in your intensive care units, you do it immediately, it is high, you say, okay, this is a bacterial infection. And ATS IDSA tried to look into a lot of papers on the procalcitonin, and there was a summary statement I would recommend people should also read, that our myth is that PCT will be positive in bacterial infections and it will be negative in viral infections and fungal infections. So it has been found to be positive also in fungal infections, and very high levels have been found also in viral infections. So by no way PCT coming out to be negative can withhold the antibiotics. So you need to give them antibiotics, and empirical antibiotic has to be started in a patient who is admitted with a community-acquired pneumonia, whether the PCT is positive or whether the PCT is negative. So that's why the guideline has very clearly made one of the statements very strong, that the empiric antibiotic treatment is not driven by the serum procalcitonin test. So irrespective of the result, maybe it's good to monitor the patient which way it is going, but definitely not at the point of decision making to start or not to start antibiotics. Other biomarkers have been also looked into last couple of years, like CRP and some of these pathogen-based tests like streptococcal and Legionella, as I showed you. And again, they have not reached that threshold where the recommendations would come that you should use it. So again, I would say that if you want to use them with a lot of caution and understanding that sensitivity and the specificities are not of that threshold that you can blindly follow them as a biomarker, which is really like something which you want to tell you that yes, it is there or it is not there, it needs treatment or it does not need treatment. So that kind of decisions you want from the biomarkers. Now that's what the biomarkers are. So what it means is, as far as community acquired pneumonias are concerned, in fact one of the study tried to compare it, all these biomarkers, 6 of them together, and pool them vis-a-vis what you have from this pneumonia severity index and other clinical parameters, and they found that they are almost equal. They do not do anything more than that. So if you do your clinical work well, you actually don't need these biomarkers. And of course, now we have for atypical organisms also. We have PCR-based methods for Mycoplasma, Chlamydia, and these are also being used in more and more in clinical practice. But obviously, the cost of the therapy is going to go high. If you are going to ask for so many rapid PCR-based tests for a patient of a pneumonia, so you might be spending roughly about, I think it comes to about 40,000 rupees for these kind of complete tests to be done. So if a pneumonia patient has to pay this much for it, then empirical antibiotics still holds true, unless and until you have a specific subgroup of patient where you expect those organisms which are likely to be resistant, and the therapeutic decision is going to change after that. So as far as the treatment part is concerned, we are still at this mono versus dual therapy. And that depends upon severe versus non-severe. So if it's a non-severe, monotherapy is good enough. Beta-lactam still holds true. And when you talk about severe or those other conditions in which there are some comorbid conditions, then you go for a dual therapy. And the dual therapy, the second antibiotic is always taken as macrolide as far as India is concerned, not levofloxacin, which is a choice for the people in the West. And if the patient happens to be sensitive to macrolide, cannot use it, then the choice is to use doxycycline. So this is a kind of chart you can see for a mono or a dual therapy, and you can see that mostly what we are looking at is a beta-lactam, cefotaxime, ceftriaxone, cefuroxime, amoxicillin, clavulanic acid. And the individual physician's choice on them would depend upon the availability in the intravenous form as well as oral form, the same molecule, or you need to switch the molecule. Also whether it is once a day, twice a day, thrice a day, 4 times a day. So obviously all those factors will determine which physician will prefer which one as the first. But by and large, you can see all of them are equal when you start treatment for a community acquired pneumonia in the hospital, or maybe in an oral therapy when we give them into the non-hospital settings. So this is the data on oral cefuroxime, that you start with parenteral and shift then cefuroxime orally. Similarly, amoxicillin, clavulanic acid, you start with the intravenous, you shift them into the oral forms, and the outcomes remain the same. I think the very important aspect which comes from these studies is that although the name is a severe community acquired pneumonia, but that does not mean that by just writing severe community acquired pneumonia, we need to treat them with something like 4th generation cephalosporins or with meropenem, imipenem. It's not there. The organisms responsible for severe community acquired pneumonia are the same as any other community acquired pneumonia, with the strep pneumonia as the most common cause, and hence the treatment algorithm remains the same. Only thing is the allocation of the patient to the ward versus the intensive care unit will change the moment you use the word severe community acquired pneumonia. Second group of pneumonias which are equally bad or perhaps more bad is a nosocomial pneumonias, and obviously instead of 25%, the mortality is 2 times, that is about 50% in them. And here also the mortality will depend upon the severity at the time of diagnosis and whether bacteremia is there or not, and very importantly, comorbidities. But at this point of time, nosocomial pneumonias will also have a lot of impact on the outcome depending upon where the patient is coming from. In the hospital, is he coming from the ward? Is he coming from the ICU? Which ICU it is coming from? Is it coming from burns ICU, neuro ICU, cardio ICU, or a medical ICU? So ultimately, if you see in community-acquired pneumonias, the outcome is dependent upon where the patient is coming from, whether it is community or a hospital-acquired pneumonias. That remains the same. But very importantly, the identification of causative organism as well as additional comorbidities is very important in deciding the therapy, because it will not be that simple to take a call as it happens in community-acquired pneumonia. And we do a lot of bronchoscopic valves as well as non-bronchoscopic valves in these patients, particularly whether they are ventilated or non-ventilated, it will depend upon them. There's a latest data which has come up which tried to compare the bronchoscopic and non-bronchoscopic valves in this critically ill hospitalized patients. And what they found was that definitely if you do a bronchoscopic valve, you get more organisms isolated, which is true. You will get samples from the lower respiratory tract. And you pick up more co-infections also. So instead of one bacteria or one virus, you may get a bacteria and a virus, you may get multiple bacteria. So you get more organisms and you get it in more cases if you do bronchoscopic versus non-bronchoscopic valve. But the most important thing is that what you pick more in a bronchoscopy is actually the viral pathogens, not the bacterial pathogens more. And that is why the entire study, when was analyzed, what it found was the outcomes are not different. So whether you did for a causative organism a bronchoscopic valve or a non-bronchoscopic valve, survival didn't change. Because the bronchoscopic valve did pick up more organisms, but more organisms were of viral origin, for which you anyways couldn't do much about it, because whatever the antiviral you had to cover, whether it was considering for the influenza or any other, whatever you have already given to these patients of severe community-acquired pneumonia. Because there is also a guideline now in a patient with a severe community-acquired pneumonia, when he gets admitted during the influenza season of that country, you need to give them oseltamivir. And very importantly, if you look at the ATS guidelines, it tells you irrespective of which day the patient has come. It is not that you say, oh, this patient is transferred to us after 7 days. What's the point in giving oseltamivir? The indication is you have to give it and you have to complete 10 days. So it's like any time you diagnose in a hospitalized patient with severe community-acquired pneumonia that he has also influenza, treat them immediately. So that's the new guideline which has come up. The MDR pathogens which we pick up in nosocomial pneumonia depends upon the risk factors. And for MRSA, you have lots of factors which are there. And previous hospitalization is the most important one. And same is for Pseudomonas. So upfront in a community-acquired pneumonia also, you cover for Pseudomonas or for MRSA if the patient has certain risk factors. That's what the earlier guidelines. Now if you look at it, they talk about very clearly earlier isolation of that organism in the last 3 months. So if they're in the last 1 year. So if the patient had an isolation of MRSA in the last 1 year, upfront, this patient who comes with a community-acquired pneumonia needs to be covered for MRSA. So same way, a patient who had grown Pseudomonas in the last 1 year and gets admitted with a community-acquired pneumonia now, he has to be covered for Pseudomonas, resistant Pseudomonas, because he has already isolated one in the past. This is of little complex nature in us. We don't get much of a problem with MRSA, but we do get it with Pseudomonas. Because our lots of patients do keep getting Pseudomonas, and particularly if they have those bronchiectatic patches or old fibrocavitatory or fibroatelectated lesions related to old tuberculosis. These are the ones who keep getting Pseudomonas again and again. But this is very important aspect to remember, that if these patients have a Pseudomonas and then come up with a pneumonia, then you need be very cautious about covering them with that. The other escape organism like Klebsiella, Enterobacteriaceae, and Acinetobacter also have an underlying risk factors to tell you that you need to cover them before your final results are there. But here there is more role of a rapid testing, which I have already discussed, primarily to drive your decisions for an appropriate antibiotic therapy. And this is again the same slide. It tells you that hospital-acquired pneumonia coming from a ward or ventilated patient in the ICU or a non-ventilated patient in the ICU will all have a different outcomes. And the severity keeps on worsening, outcome keeps on worsening as the patient moves from the ward to the ICU, ventilated, non-ventilated to ventilated. So this is the kind of step which shows how bad the patients are going to be. When it comes to empirical treatment, this is again one of the latest guidelines. You can see that lots of things needs to be done. But early nosocomial pneumonias, obviously not much of a decision-making process required because the organisms are going to be not different and resistant. But in the late onset ones, there is still going to be a problem where you need to look for your escape organisms. And unless and until you have OXA48, then the ceftazidime with avibactam is the one of the combinations which are being recommended. But of course, we have host of them, so I'm not going to go into detail. But of course, they will be determined by your ICU flora, as well as it will be determined by the antibiotic sensitivity which you see of your patients in the your hospital, which will vary from hospital to hospital, city to city. So I will conclude here that hospitalized lower respiratory tract infections are basically where you can have a poor outcomes. And many a times we need to look for and investigate for the etiological agents so that we don't err on choosing the antibiotics. And on the same hand, we don't have to use a very broad spectrum antibiotics like meropenem and imipenem in all of them. Viral etiology needs to be included in the diagnostic investigations, and bacterial etiology, which requires a sputum, blood or bowel, but they all have limitations, and I even showed you that bronchoscopic versus non-bronchoscopic bowel also does not make a difference as far as the mortality and outcomes are concerned. Rapid tests are there, they are going to stay, they are going to become better and better with more and more refinement, and we expect them to be more sensitive. So they need to cross the threshold of sensitivity of above 85% to reach the diagnostic armamentarium for us. PCT, which we are very strongly dependent on, is not the tool. And I think this is again a very important tool in hospital-acquired pneumonias, where the moment the PCT rises, we start wondering that the patient has got a hospital-acquired infection. For the resistant organisms, always think about the risk factors. And of course, the decision-making in hospital-acquired pneumonia is the most important thing at the upfront, to take the investigations, start the empirical antibiotics as per the characteristics of the patients, which are going to match with the likely organisms which are going to be there. So that's a kind of match which you need to do for the nosocomial infection. Thank you very much.
Thank you, Dr. Deepak Talwar, sir, for excellent overview of use of antibiotics and antimicrobials in the management of LRTR, especially community-acquired pneumonia. We have come a long way from the first discovery of penicillin by Alexander Fleming, where people used to die of a simple infection, simple wounds with a septicemia and all. Over a period of time, we have developed many antibiotics, and nowadays time has come. The judicious use of antibiotics is more important than the availability of the antibiotics. So the correct use of antibiotic in correct dosage in correct setting is very important to prevent from our antibiotics going the way they are becoming, the bugs becoming resistant to it. So that is again the one point to be considered while using antibiotics.
Okay, so we can just move on, and I have two excellent panelists also. So I will ask one question to Dr. Mane sir, that how do you manage acute exacerbation of acute bronchitis in OPD setting? especially in the elderly patient, because we are getting a lot of these patients with chronic bronchitis, and then they keep on coming to you every year. So how do you manage them on OPD basis? Which antibiotic do you actually prefer in these patients?
Yeah, actually, now this question is very specific. It's chronic bronchitis in an elderly population. Most of our elderly population, what we see in OPD, either they have a comorbid conditions, either they are diabetic, hypertensive, patients who undergone a CABG surgery, or even if they have rheumatic arthritis, so they are on some of the other treatment. All these patients with chronic bronchitis, it's very difficult to get them investigated, except X-ray chest. Probably sputum examination is it's very, very difficult. I mean, say, even in a routine OPD practice, I think we don't advise gram stain for any of these patients. So looking at whatever it is, like, then we see what the epidemiology has told us, what exactly Sir told us, that the most common organisms, and you need to treat the most common organisms. So the choice, certainly, I think, for me particularly, though there was a controversial, probably we don't use levofloxacin, and first we probably try and use azithromycin. But in my own clinical practice, I have seen azithromycin has been already given by family physicians. Patients still come to you with chronic cough and mild fever with mild dyspnea. You examine them, they have scattered bronchi. He's restless. So I think dual therapy, either augmentin or probably cephalosporin, that is Joseph, I think that is probably would be my first choice of treatment for all this elderly population. Now, as far as azithromycin is concerned, I think I probably will create a debate here. I am not too fond of using azithromycin as a first-line therapy in any of my patients with lower respiratory tract infection. Maybe, probably, I think we don't have a surveillance about resistance or to azithromycin. Yeah, so we really don't know whether the azithromycin works in this particular population or it doesn't work, but then we still give it. And what I have seen particularly, that I think I have stopped giving azithromycin to my elderly patients. First choice is, of course, levofloxacin 750 milligram. Not too many physicians I know, they use to 750 milligram, but I think when I was associated with Florida University, and that is where I learned that no, I think the US is more fond of using levofloxacin in any of the respiratory tract infection, and that is where I learned, and I still followed it, and I'm still follow using levofloxacin 750 milligram, and then of course dual therapy as or cephalosporin, levofloxacin, Joseph as my second line of treatment. I think any other comments if you want to, because this is my own personal experience. The guidelines says, as Sir said, we hardly follow guidelines. You know, guidelines we read, we go to conferences, so we become educated. We feel, yes, oh, so many, we have learned so many new things. But when we come down to our clinical practice, I think on paper we are totally different.
Every patient can't be fitted to the
Clinical requirement, especially in elderly, we have seen that a lot of MTB patients can be there. So when you give levofloxacin, you are subjecting the person to a monotherapy of a quinolone, which is not very well recommended.
I don't know.
Don't know whether.
Yeah, I agree. But once you give that treatment for 5 to 7.
Group is a large chunk of. Cephalosporin would be probably a better option as a first step.
Yeah, personally to my own parents, I think recently I've given Joseph CB as a combination therapy because he's almost 85 years old with a lot of comorbid conditions.
One thing about the use of azithromycin after the very haphazard use of azithromycin during the COVID season, I think that we should give a break for this molecule for a few months or few years so that it can again start working.
Yeah. And I've also seen a lot of prescription coming. I would ask Sir about even in COPD patients or in chronic bronchitis, people using steroids. Actually, it has no role as such, but I'll certainly ask Sir, what is the role of steroids in this particular patient?
I think one important point which you said about azithromycin in elderly is that there was some concern regarding the cardiac safety of azithromycin in elderly population, and there was missed opportunity of getting a statistical significance in acute cardiac events in the elderly people who were given azithromycin vis-a-vis non-azithromycin. So although the statistical significance didn't reach, but there was a signal that azithromycin in people, elderly people 85 and above, are more likely to have a cardiac events. But since this study was a like 1 year study, follow-up study, and there are a lot of patients who died otherwise also actually in that. So there's not a clear-cut association, but I would also be very hesitant in using azithromycin a lot.
So I think we can conclude with this first question that we all agree, is it in elderly patients, I think it is amoxiclav along or a cephalosporin along with maybe a macrolide. So that should be the antibiotic of choice for acute bronchitis. I think all of us agree with this. Amoxiclav or cephalosporin along with a macrolide. Levofloxacin, as sir has mentioned, that yes, it is my favorite molecule as well. But as Dr. Dharmadhikari sir rightly pointed out, that because of the I mean, we all are worried about basically tuberculosis in our elderly population. So we try to avoid levofloxacin in these particular patients. But when you're sure, or in fact, there was a paper in between which I don't know which I should be mentioning it over here. There was one paper which I recently read which said that 5 to 7 days of oral levofloxacin should not be actually making your patient diagnosis of tuberculosis dicey. So that was the one paper which I just, but I think it will add more into the confusion. So what do you say? Your talk on, your say on this, Dr. Talwar, that.
No, I know that. So actually, what happens is that the tubercular bacillus loses the acid fastness with the levofloxacin. So that happens in 5 days. But you can still pick it up. But then most of the times in a routine, it will go as a gram negatives, not as a MTB. So that is how it is missed. But you are right that there is a paper which confronted this earlier paper that 5 days of levofloxacin can make the diagnosis of tuberculosis delay by 3 weeks, and it can even 7 days of levofloxacin can produce levofloxacin or fluoroquine resistant, and that is the two papers on the basis of which Indian guidelines completely say that you should not use levofloxacin in the management of community-acquired pneumonia unless and until you are sure that it is not tuberculosis. Unless and until you are sure. So that is on the physician actually. So if they are sure that this is just a pneumonia, then fine.
Point very well taken. And we have papers where even upper lobe pneumonia presenting as tuberculosis presenting as only upper lobe pneumonia or community acquired pneumonia is very, very common. I mean, in fact, it's almost 15 to 20% of our community acquired pneumonia can be because of tuberculosis. So I think we should not be considering levofloxacin in these, particularly in the elderly patients. So we should not be considering levofloxacin. So I think as we have touched upon this cephalosporin, I would like to ask each one of us, including me, that which cephalosporin do you prefer in your community acquired pneumonia or an acute bronchitis setting in OPD practice, whether it is a cefuroxime, whether it is a cefuroxime, whether it is, I know that it is a question, I think it's a more a personal choice, but we'd like to ask everyone, maybe, Dr. Mulchandan.
With regards to the cephalosporin, if it's not again a structural lung disease, in oral formulations we don't have a cephalosporin which would cover Pseudomonas. So cefuroxime is the go-to, more for because of the habit what we've gotten into. That's one, and also because it covers strep pneumonia very easily. And drug-resistant strep pneumonia, we in hospital have not documented much. So I'm not sure of what is the data, but whatever cultures that we've gotten positive for strep pneumonia, we don't have cefuroxime resistance, which is documented. So that gives us confidence to use it on outpatient basis very easily.
Yeah, about the cephalosporins, I have been using almost 60 to 70% of the time cefuroxime for last 20 or more than 20 to 25 years. And we have been getting the consistent results. That is the beauty of this molecule. Even after using for so many years, the results are still same. So the second choice is always cefixime, but the first drug of choice is cefuroxime.
Mani sir?
Yeah, same. I think This particular molecule, we have been using it for a longer period, so we have a long experience about this. And plus, I think what I would say is the GI adverse effects are also quite less as compared to any of the other molecules if what you would use in probably in community acquired. I think.
So I think for me, when I look at them, I look at two things, that amoxicillin clavulanic acid and cefuroxime clavulanic acid. And clavulanic acid is an important feature which I will look for in cefuroxime for it. So that's why these are the two things which I generally use in practice. Augmentin is for any infection in the body. If you look at any consultant of any specialty, it is a standard, a co-amoxiclav or amoxicillin clavulanic acid. So I do not know about its resistance pattern or previous usage. So that is why I also personally use this combination, but I use it for clavulanic acid combined with it. So that is why, which gives me more confidence to use it. That's the only thing. But amoxicillin clavulanic acid is the only other thing. The problem is giving 625 twice a day is nothing actually. If you use right dosages, then it is worth using it. So generally, I think I find a lot of people just giving 625 twice a day, which is like grossly misusing the antibiotic. So sometimes you want a twice a day, but not a big number, but still effective. So there are many factors in the mind, and in fact in the patient's mind also. The 1 gram, the moment you tell them 1 gram BD, so immediately, oh, 1 gram BD, it's like a big thing. So they are all things in the mind. So we change our practices according to the mind of the patient, as well as trying to get into where, we are also happy and the patient is also happy. Because if he doesn't take at the end of the day, then I think the entire thing is lost.
I just want to share one small experience. This was just probably 10 days back. One of our Pune people had gone to Bangkok, and he had an lower respiratory tract infection, and he was coughing so he was scared whether it was COVID on travel, whether he had it. He got all the tests done, and then I told him, now don't panic when you are in Bangkok. Be calm and just go to the medical store and ask him for an Augmentin. And what I prescribed was 625 milligram 3 times a day. But then he said, doc, it's not available. It's 1 gram which is available. I said, but 625. He says, no, we don't have it.
Now, because we have touched upon this, so we know that amoxicillin and clavulanic acid, they act in a synergism. Okay. So do we have enough trials? Because we get carried away many times with many of the companies coming with combinations of cefuroxime along with clavulanic acid, cefuroxime along with clavulanic acid, cefixime along with clavulanic acid. Do they really have that much of synergy to combine these two molecules? So I would like to ask Dr. Talwar about this.
I will pass this question.
I would like to use the higher concentration of the molecule. Instead of using 250, use a 500 BD instead of adding the clavulanic acid.
Biomarkers. One more point which about procalcitonin coming from ICU. One point is that a lot of times we've seen that the use of antibiotic choice, suppose if it's a carbapenem versus a cephalosporin or a second generation, third generation cephalosporin, will be decided on the level of procalcitonin. Yeah. Which I feel is an approach we should do away from, where there's no cutoff which is defining a severe or a resistant organism versus a sensitive organism. Like sir mentioned, most of the times patient in ICU with a lower respiratory tract infection and respiratory failure are actually just a sensitive strep pneumonia. That is one. In immunocompromised patients, procalcitonin is not validated as a test. So that's again in neutropenics or dialysis patients or patients who are on immunocompromising medicines. That's one test where we should not be relying on.
So in fact, procalcitonin becoming negative is a point where you can
that's
stop
right.
the
That's right.
antibiotics,
Yeah.
but not to start the antibiotics.
Right.
It's maybe to end the antibiotics. So all the studies are more supportive of end point,
Right.
not the beginning point.
In fact, we've seen patients, this might sound funny, but patients with myocardial infarction where there was pulmonary edema, and later on, the next day the 2D echo was done and the LV filling pressures were very high, and the procalcitonin was 70. Okay. And this is where sometimes, and even with CNS issues where patient has got a IC bleed with a patch, which could be just chemical pneumonitis, and the procalcitonin was high. So incidents where sympathetic storm is why procalcitonin can mislead you to think that this is a resistant infection.
Great, great. I think point very well taken. We should not be judging our antibacterial therapies based upon the initial procalcitonin levels. You can definitely use them to cut down your antibiotics if the procalcitonin levels are coming down or if it becomes negative. So moving on to next question. Should oral cephalosporins be the first line treatments of at-risk elderly patients with mild to moderate or moderate to severe acute exacerbation of chronic bronchitis? So I think this is again answered in our discussions up till now, but I think we don't have studies to say amoxiclav versus any cephalosporins, but as Dr. Talwar sir said that if we are using amoxiclav, it should be in the correct dosages, 1 gram twice a day and not 625 mg twice a day. I think we can move forward with this, yes. So we have another question which is chronic bronchitis COPD case with moderate to severe infection in OPD setting. What is your drug of choice? Moderate to severe, I think again this we have answered that it should be cephalosporin along with a macrolide group of antibiotic. Yeah, so moving forward, because we are discussing about community acquired pneumonia, I think I just want to ask from everyone that how long do you give community antibiotics in CAP? For example, many times we see that even after 7 days of maybe oral cephalosporin for OPD patient, the patch has not resolved, or a patient with chronic bronchitis and he's still having this yellow flame and he's symptomatically better, he's improved, but he has covered 7 days of antibiotics and still do you continue with the antibiotics, you step down or you give a small dose, or do you continue or you stop the antibiotics based upon your clinical judgment?
Like you said, that if the patient is clinically improving, the sputum color is changed or is still yellow, but the symptoms are better, his breathlessness is resolved, no fever, then I'll be very keen to stop antibiotics at 7 days. Radiological resolution should not be an endpoint in CAP patients. Probably 1 month later you may do an X-ray, and only 50% patients are found to have complete radiological resolution at 4 weeks. And probably X-ray would not be the best marker of endpoint of treatment.
Do we all actually follow this? I tend to give it 3 more days.
I think it's a very good point which you have brought for the discussion, that the guidelines tell us to treat them for 5 to 7 days. So 7 days is the general one which is considered as the cutoff, which is true in most of the patients. But the important point to remember is that all patients are not same, number one. Number two, comorbidities will make a lot of difference in your decision-making process. And in respiratory practice, when you have an underlying disease in the lung, which would be in some way or the other, will dictate that the treatment has to be continued. So that's why I think by and large, the guidelines are good for the guidance to large number of patients, but does not hold true for every patient. And then you have to take a call on your individual patient. Like if he is having a yellow sputum at the end of 7 days, even I won't have a heart to stop it, that the patient is looking better, because I know that this patient can come up with a relapse little later. And then I'll have a more difficult job to do to give another antibiotic, which will be then intravenous in that case. So entire scenario will change.
Yeah, one question to everyone. While disclosing the prognosis to the relatives and to the others, we have different parameters with us, like neutrophil count, total leukocyte count, neutrophil to lymphocyte count, and CRB65. So on which you believe little more, or which one is better marker of the prognosis of the patient?
I think clinically is what I think probably, as Sir said, biomarkers, to depend on biomarkers and treat patients will be very difficult in OPD basis. I don't think so any of you for a lower respiratory infection ask for an CRP. Of course, often during COVID, we have got used to ordering CRP left, right, and...
No, patient themselves will get CRP.
Yeah. They will get it done. But otherwise, I think hemogram probably is one thing probably will probably ask. Otherwise, you don't even ask that also for a patient who comes to an OPD. I think that is what my opinion is.
a patient of community acquired pneumonia, when diagnosed, correct organism, correct antibiotic, in spite of that, there is a high mortality. Why is this? Especially pneumococcal pneumonia. So what are the extra pulmonary effects of pneumococcal pneumonia?
I think it's a very valid question, and I don't have the answer for this because no, he's saying the exact antibiotic, the sensitive antibiotic has been given. I think when patient asks such kind of questions, we just look up and we say that certain things even we don't know. But I think we never know the exact bioavailability of the drug. We don't know about the what the drug is doing inside and the for example, there was a study where in tertiary care setup, just like we say that in myocardial infarction, the streptokinase should be given within 2 hours or within 6 hours of this insult. Same way for CAP also, we have to give antibiotic within 1 hour of that patient's admission. And if you see in any of these tertiary care hospitals, the time the patient comes inside the hospital till the time the antibiotic is administered, I think it is a long time. Okay, many times it may be up to 4, 5, 6 hours also that the patient doesn't get. I think this is one important factor that many of the times the initial you are hitting the organism, that may be one of the reason the time is very important. Second is many times there might be some complications like streptopneumonia developing. One of my senior, so he died because of streptopneumonia, senior doctor in Ruby Hall itself. So that time also we observed that it was basically delay in the treatment, maybe one of the thing, but these patients are sometimes because of the immunity defect, he developed pleural effusion, empyema, and so those were the complications of streptopneumonia which were not addressed correctly. So maybe you are giving right antibiotic, right dosages, but the patient has developed empyema, so you may be actually requiring a thoracoscopy or something to drain it. So that was, I think, some of these complications may need to be addressed even if you are giving correct antibiotic, correct drug, but the complication needs to be addressed. Any?
Point is that, strep pneumonia has more than 90 serotypes actually, and all of them don't behave the same. Some of them are very virulent, some of them are not that virulent. And we don't do the subtyping, and even the vaccine does not cover all of them actually. So there is a issue about the virulence of Streptococcus pneumoniae, which will be the determining factor that still we will lose that. Like somebody dies with a strep pneumonia, even now in our ICU, it really likes, I go back and think that why did I lose a patient of streptopneumonia actually? It shouldn't have been lost. But then this is the truth that we continue to lose them. Even now we continue to lose them. It's a big killer as far as pneumonia is concerned. And there we bring in always the vaccination and vaccination for pneumococcal vaccine.
A small thing about the topic came about bioavailability, and I'll share my one small experience when I was doing a clinical trial on imipenem. And I was a principal investigator, and I had a sub-investigator I was supposed to be a blind investigator. And Dr. Zirpe, who was in the ICU, you probably knew what is he giving. And it was clearly instructed that that particular molecule is to be dissolved in 100 ml of normal saline to be given at one specific rate. And the placebo was and there was a placebo, so that was to be dissolved in 200 or 500, I don't really remember. And by mistake, probably he had dissolved the wrong bottles into the wrong configurations. And when the audit came up, and that was a big issue. So I was wondering that, we are in a clinical practice. So I was called in Bombay by Quintiles, and then they said, this is what happened, Dr. Mane. And I said, I was blinded. But I asked them, what exactly is the cause? I mean, why should I have given the antibiotic as a full dose? And that is where I probably learned what is the meaning of bioavailability of that particular drugs. It's very important. We usually write down a molecule, like, okay, meropenem 2 grams 3 times a day, and we leave it to the sisters to give that meropenem or imipenem. And she gives it by her choice at whatever rate she wants to give the particular molecule. I think that could certainly also affect the outcome of an antibiotic in a particular patient's, any infection. Not particularly pneumonia or something, but I think that could affect any infection. And that is probably one of the reasons why probably we feel that, oh, in spite of the fact that I have used meropenem, imipenem, ertapenem, and still I don't get results. I don't know, so your call on this?
I think you are very right. PKPD is a very important aspect of the drug, and you may be giving the appropriate and the right drug, and still it does not work. You have given that beautiful example, because at the end of the day, we forget that the drug has its own characteristics and the human body has its own characteristics, and if they do not match, and that what we call as PKPD, if they don't match, then even the best drug may fail. Actually, it may not work. So that's a very important point actually which has been brought out, and it's an excellent point that we see the failures even with the highest end antibiotic, and we see the success with the lowest level antibiotic also.
Just I want to highlight the 2 points regarding why the patient is not responding. One point what I want to highlight is the switching of antibiotics.
Yes.
Most of the time the duration of antibiotic given, they are not given for a proper period because just patient was sometime VIP or a lot of pressures. After 2 days suddenly patient was shifted to another antibiotic or a higher antibiotic. Probably the proper duration of antibiotic, what we required to see for the response, was not followed. Maybe switching of the antibiotic, day 1 you giving ceftriaxone, day 2, day 3 immediately they are shifting on Tazara or whatever it is.
Yes.
So this is the one reason where the proper duration of antibiotic was not given to wait for the response. One point what I see clinical practice. Second point I want to mention, as we are an adult physician, we forgot dose per mg per kg. Most of the time, sometimes patients are too high weight,
Yes.
90, 100 kgs, and the dose what we are recommending for adults, sometimes they are not adequate as per his weight. So this point is sometimes missed by us, and we are under giving the doses as though they are standard, but they are not matching with the weight of the patient. So that may be one of the reasons where we are not getting an adequate response to the antibiotic.
Very, very valid point. And do we actually wait for 48 hours for the fever to subside and then change the antibiotic, or do we get pressurized? So I think we all get pressurized. We tend to change the antibiotics on the second day itself if the fever is not going down, because the people want it like magic. The patient has come, you are given 1 shot of antibiotic, the fever has to subside. Yeah.
Yeah, one of the point for patient not responding to the correct antibiotic on the correct organisms, what pneumococcal pneumonia, in addition to the bacteriological, it has caused a lot of immunological damage into the body. Yes. That damage cannot be controlled or can be cured with the antibiotics. So that damage is probably responsible for the mortality.
Anyone else?
Modi, just in addition to Dr. Mani's patient asking for a hemogram. Everything is normal, but the patient with the highlighted eosinophil count high, more than 800 and all. How do you go about it?
I didn't get it.
Eosinophilia.
Eosinophil count high. And you are saying in the patient of pneumonia?
Yeah, I think we come across a lot of eosinophilic count which has been raised. Probably it's more like a reactionary than whether to treat. I think if you treat with antibiotic, I think the later follow-up hemogram will show that I think the eosinophil count, total eosinophil count has come down. What is your experience?
So, if upfront the eosinophil count is high, that generally very rare for us to see. I have not seen. But yes, on the therapy, eosinophil count going high is an indication that there is a drug-induced eosinophilia, basically. And at that point of time, we really need to understand that even cephalosporins can all cause eosinophilia, peripheral eosinophilia. You need to keep that in mind. But if somebody comes with an LRTI with eosinophilia, if I can recollect, the only reason is when the TLC counts are very high. These are patients who already have some eosinophilia and the numbers multiply too much and they look a big number at that point of time. And it also happens in some patients with an acute stress situations where the eosinophils are high and they come down over a period of time. So you just follow them, it just comes down. But yes, this will be like eosinophils are supposed to be not pushing them for infection actually. They are supposed to be protecting them from that. But in this situation, if it happens, then you start looking for other thing which is happening in the patient. Something else is happening which is wrong, and you may get or you may not get to know about it. So this is a very big challenge in eosinophilia. Many times we do not know the cause of it, and it goes away by itself, and you are also happy that finally it has gone. But then if it sticks around, then it actually sticks around to you also, because the patient will keep bothering about that कि ये तो ठीक नहीं हो रहा है.
So we have just couple of 1 or 2 questions. We have discussed a lot about CAP. So although today's topic is not about HAP, I would like to ask Dr. Talwar sir about one question about this. European guidelines recommend that antibiotic treatment for hospital-acquired pneumonia should not be longer than 7 days, especially since prolonged antimicrobial therapy promotes resistance. My question is on the viability of this recommendation, since duration of treatment for multi-drug resistant pathogen is not clearly established. So your comments on this. I think we just discussed about CAP in this particular setting. So about HAP also would like to know.
When I saw this question, this was the most controversial question actually which you have asked me, and I think Jay should be able to answer this better. But in my experience, that I do realize that, all the guidelines tell us that 7 days are good enough, you can go on to 9. But if you have a drug-resistant Pseudomonas or Staphylococcus, you can go on to 14 days. Sometimes even longer than that may be required. That's the standard guidelines. But when you said in practice, when it comes to, you have a hospital-acquired pneumonia, 50% mortality, and day 7, are you sure that you can stop it? Are you comfortable in stopping it? So that's a very big question actually, because you don't want to lose this patient. You know that you are about to lose this patient, and if you have brought him on 7 days down the line where he's doing really good, will another 3 days really harm the patient? And especially in those situations when we do not know the organism. If we had known the organism, like Acinetobacter and Pseudomonas, you already have a guideline to extend the therapy. But in routine, you don't have a way to extend the therapy. So in those situations, I think you tell me what you do, because I am not able to have the courage to put a stop there.
So I'll tell you the situations where I do have the courage to stop them and where I don't. If it's an Acinetobacter or a Pseudomonas or an MRSA, then definitely we don't have the courage to stop before 14 days. That's one. If we have an initial procalcitonin probably done on day 2, day 3, which is say 10, and if it's come less than 25% of the initial value, if it's come below 2 or below 1, or if it's come as an absolute value below 0.5, where I'm treating a bacterial pneumonia, that gives me the courage to, okay, this is the time to stop. And probably even if it's day 8, or if it's, I don't know where the number 7 or the number 5 comes, that 5-day course or 7-day course. It's not proven by any science that 4 days is better than 5. So, but with time, we've realized that short is sweet. And with the most, the usual, if I have a strep pneumonia, and the patient improving, the patient is off oxygen, the cough is resolving, and the procalcitonin or the WBC count has come down, or a CRP level, that gives me the confidence that we stop it. But I think Acinetobacter, Pseudomonas, and a resistant Klebsiella or an MRSA, that's where probably we'll be, using a longer duration like 10 days or 14 days.
Yeah, the trials were primarily looking at whether the 7 days, 10 days or 14 days. But they did not stratify according to the organism. So they just showed that the results are same at 7 days as compared to at 14 days, as compared to 10 days. And that's why they came to this 7 to 8 days actually. That's how the recommendation.
I think another important point which you did make, sir, is that the patient in pictures needs to be taken in consideration also. So we need to look at what his immunity may be, like if it's an uncontrolled diabetic or a CKD on regular dialysis, someone who's on, now recently we had a lot of use of baricitinib, someone who's on such molecules, whether you'll be inclined to stop antibiotics at 5 days, that will be really courageous. So probably in those situations, longer durations will be more beneficial than risky for the patient.
I think this confidence of stopping antibiotics earlier has come by the method of doing procalcitonin at day 5, day 6, day 7, and they have realized that the procalcitonin comes down at day 5 only, so you can stop it. And they've taken this chance, and these are the results.
Okay, I think I will just ask anybody in the audience has any question. I have only one last question to Talwar sir, because you mentioned about the multiplex PCR and these biofire tests. So where do you actually use them? Because some of these tests are so expensive. Like one of my patient, he paid 50,000 rupees for a stool biofire, and then he was like, for my gastroenteritis, if I'm, and it was done on 2 or 3 attempts. So for a stool biofire, if patient has to pay 50,000 rupees, where our amikacin, metronidazole, these kind of cephalosporin, so these antibiotics do work. Whatever VIP kind of patient, and you get carried away with these kind of tests. So where do you exactly put these tests in your practice?
I think this is something which is very, very apt at the moment, because the test is available. And the test is available and it is easy to perform, but definitely not on the stool examination, but on a true lower respiratory tract secretion. The problem is when you do it in a sputum, then everything in the throat comes out to be positive, and many of them are resistant. So like interpretation of a biofire test is the most important thing. However, if a patient gets admitted and gets ventilated, then I'll be happy to do a biofire on that patient. But if this patient comes from another hospital, I know what is it going to show, whether I do a biofire or I don't do a biofire, because I know what kind of organisms would have come from the other hospital. So this is a very expensive test, very easy to order, but I tell everyday residents in the morning, because in the night they have already ordered and it's not for me to get it back actually, because the billing has been done, the test has been done, the report is already there in the morning rounds, and you really wonder that, you know what. So I keep scolding them that when this test is ordered, please look into it, that can you interpret the test and translate into therapeutic outcomes and the therapeutic decisions, and if you cannot, then please don't ask for this test at all, because it will make life miserable. So for sputum, I'll say simply we don't do it at all. We'll not do in the sputum. We'll go for conventional cultures, and if required, we will do definitely the urine test for the rapid test basically. But for a ventilated patient, yes, for a ventilated patient with a severe either nosocomial or the community-acquired pneumonia who's really not doing well, got ventilated, at that point of time we'll do it. But it is very disturbing, because in this biofire you have all the resistant pattern also picking up. So they will come OXA48 resistant. Now you are into trouble. You had started with 3rd generation cephalosporins, and now you have to jump straight away to colistin and polymyxins in these patients. So the life becomes suddenly very difficult. And then you know from there you have actually nowhere to go. You have basically reached the end of the tunnel for that. So this test must be used judicially, and make decision before ordering the test that how you are going to interpret the test. And if you do not know the answer to that, then please don't get it done.
So just 2 points, just I want to ask to all the panelists. The patients which is routine community acquired pneumonia and treated with the 7 days of antibiotics, probably beta-lactamase or whatever it is. The patient improves a lot, but too much big pneumonia, and after completing the 7 days, though there is a clinical improvement, there is a large, huge pneumonia, I am afraid of stopping the antibiotic at that time, clinically, even if it is improved. So in such situation, for switching this patient to an oral antibiotic, whether you recommend the same group of antibiotic or you can switch. Already we have given a 7 days of support cephalosporin or a beta-lactamase. So after discharging the patient, can we give a same group of antibiotic for the further 5 days, or you can shift to the another group of antibiotic, like maybe macrolides or maybe quinolones, whatever it is. What is the ideal guideline? And second point, just I want to highlight, not just those, as we are differentiating pneumonia into mild, moderate and a severe category. Most of them mild and moderate may be managed on OPD basis, and they also improve, even though are community acquired pneumonia. But what my personal feeling and whatever the recommendation is there, in severe form of pneumonia, giving a single antibiotic, maybe a beta-lactamase or a imipenem, whatever it is, for 14 days isolated, rather than we can add from a day 1 a polymicrobial antibiotic. It has shown a better result that giving a common therapy of a 2 different groups in a severe pneumonia definitely going to have a good result and cut short of the duration of the hospitalization. What is your opinion?
So there are two different things. One you said about, I'll take the last point first, which is the most important one. You said that in severe community acquired pneumonia, you use dual antibiotic therapies and you use the antibiotics which you spoke about. In severe community acquired pneumonia, dual antibiotic is recommended. But in the dual antibiotic, the one is beta-lactam beta-lactamase inhibitor, and the second one is actually either a levofloxacin or a macrolide or a doxycycline. Adding another antibiotic to that is like looking at something which should have some risk factor for that. Like if you have MRSA, you will use a gram-positive cover for that. If you have a Pseudomonas, then you will be justified for Pseudomonas, Klebsiella, Acinetobacter. So those things are dependent upon, as per new guidelines. You know, previously there was there that if you have a chronic lung disease, you cover for Pseudomonas. If you have a patient with a burns or a patient who's a diabetic or who is on a central nutritional supplementation of parenteral lines, you give them MRSA cover. Now the guidelines are very clear that this has led to a lot of misuse actually. So prior isolation is the most important indication for using cover to Pseudomonas by another antibiotic and for MRSA cover for if the patient has grown MRSA or shown MRSA in the last 1 year. So 1 year is the period which they are talking about. But by and large, the severe community acquired pneumonia only means that you need 2 antibiotics. One of them is basically to cover the atypical organisms, which is the levofloxacin, macrolides, as well as the doxycycline if the patient cannot take any one of those 2. But the first choice is a beta-lactam beta-lactamase inhibitor. The second question you said that whether you switch them or you change them or what you do, there's no guideline to that, but it is very clear that whatever you are comfortable with intravenous, you will be more comfortable in converting them into the oral form if it's available. And that is the reason why I think previously the comoxiclav was so hit, because that could be easily merged into the oral one and go. Now we have other cephalosporins also available to us, which are available both in IV as well as in the oral. I think that makes the life very easy, because at that point of time, you are converting because of 2 reasons. One, you don't want to keep the patient in the hospital, you don't want to continue with the IV therapy, you want to switch on to the oral therapy. You might take this decision on day 3, day 4 itself, why day 5 or day 6? You might take it earlier also. But you want to have that confidence that whatever has worked for the initial 3 days will continue to work for your next 5 days. And that only comes when the molecule remains the same. As far as I am concerned, I never class switch or even switch between the molecules of the same class, just considering that all are same, all cephalosporins are same. I don't go by that. I would preferably, once I start with the IV, I will choose the one which I can follow up with the oral one. And at the time of discharge, oral has to be done. And as I always say that financially, you might have to discharge the patient even on day 3. Be prepared for that. Change them into oral, that's fine. Only thing is, if the patient is good and bioavailability is not going to be hampered with an oral antibiotic, he can go. Otherwise, you have to send them on the intravenous only. That's what I do. Absolutely. That will be the best situation. I think this will be more like a best clinical practice rather than the evidence for that, but it will be a best clinical practice.
Yes, I think, but there are so many times that, for example, patient is on piperacillin tazobactam and you want to convert to oral antibiotic. We don't have a substitute for that. So then there is maybe cefuroxime along with clavulanic acid or cefuroxime along with clavulanic acid. So that is how we are trying to convert this. One more myth in this is, if the patient is meropenem, many of us, we try to convert this patient on oral pharopenem. But meropenem has an absolute different spectrum, and pharopenem doesn't cover your pseudomonas. It is non-pseudomonal. Pharopenem was basically for MDR streptopneumonia. So I think there are certain points which we need to be considered when we are switching. It may not be available, the same group of IV to oral, it may not be available. I think we can just, yeah, so thank you everyone, and I think we all have understood why He is actually the master for this, taking this master class, and lots of insights and lots of very valid points, practical oriented points. And I know that although he was talking about the guidelines, he has always given us very well practical implications that no, you can't start the antibiotics at this point of time. We have to take clinical decision. So I will like to thank Dr. Deepak Talwar and Dr. Kavedia as a chairman. He will like to give the concluding remark.
Thank you, Dr. Deepak Talwar, for excellent oration, excellent understanding about the different antibiotics and their rational use. Thank you, sir.
First of all, I would like to thank Dr. Deepak Talwar sir. In his busy schedule, he has given us time for doing this CAP Masterclass. This is the first CAP Masterclass, and of course many more to come. So thank you, sir. And of course our chairman, sir, Dr. Mahendra Kavedia, sir, for his guidance to this CAP Masterclass. Our moderator, Dr. Mahavir Modi, sir, for his excellent moderation and throwing some very tricky questions to all the panelists. And Dr. Abhay Mane and Dr. Mool Chandani, thank you very much for giving lots of pearls of wisdom to this group. I think this particular CAP Masterclass was possible only because of churning out a lot of ideas and exchange of this expertise. So thank you very much, and that's why we call this from the expert for the expert. Thank you very much, all of you.